Hello, everyone. My name is Anita D'Souza. I'm a professor of medicine at the Medical College of Wisconsin. And today I will review the timing and co-occurrence of red flag symptoms prior to a diagnosis of light chain amyloidosis. So light chain or AL amyloidosis is a multi-system disease in which extracellular deposition of misfolded and aggregated amyloid fibrils occurs. These fibrils are derived from free light chains, which are produced in clonal abnormal plasma cells in the bone marrow. What we know is that many patients with AL amyloidosis have multi-organ involvement, wherein organs such as the heart, kidneys, nervous system, gastrointestinal tract, among others, are often affected. The disease entails very distinct and disparate appearing symptoms across different organ systems over time, leading patients to seek healthcare with multiple specialists. And more than a third of our patients report symptoms for a year or longer, and approximately half of them seek care from 4 or more different specialists before their AL diagnosis is formally established, suggesting a long delay in time from initial onset of symptoms to the diagnosis of AL amyloidosis, something that we have to shorten. These are some of the red flag symptoms that occur, and these depend on which organ is involved or affected by amyloidosis. So for example, if there is cardiac amyloidosis, a patient may be diagnosed with cardiomegaly or cardiomyopathy or heart failure. If there is renal amyloidosis, there may be proteinuria or chronic kidney disease. And so we created a constellation or a group of these red flag symptoms that we have then differentiated by organ system. And we have tried to study this further in this current analysis that we did. We don't know the timing and co-occurrence of these red flag symptoms before the AL amyloidosis is formally diagnosed. And so we aimed to examine the incidence, timing, and co-occurrence of specific conditions likely to be the symptoms or signs related to AL amyloidosis in the 3 years prior to a patient's diagnosis of AL amyloidosis. So we used a data source called as the TriNetX. This is a health research network comprised of many different healthcare organizations. And at the time of doing this study, which we restricted to the US, we had 62 different healthcare organizations reporting data to the TriNetX. We identified our cohort if a patient had 1 or more inpatient or 2 or more outpatient visits with a ICD, which is a diagnostic code for AL amyloidosis. And we chose October 1, 2015 to start our period, because that's when the ICD-10 system came into effect for amyloidosis, and it is able to select AL as a subtype until the end of 2020. We also required patients to have received chemotherapy at least 3 months to up to 1 year after the diagnosis of AL amyloidosis. And we required all patients to have at least 3 years of backward medical history within that TriNetX system prior to the diagnosis of AL amyloidosis. And we looked at the red flags that I just showed you, and we considered the time from red flag condition to AL diagnosis as the date of the earliest medical encounter for the specific red flag to the date of AL amyloidosis diagnosis. In terms of how we analyze these data, so what we considered as AL amyloidosis diagnosis as time 0, and the electronic health record period preceding time 0, we can then look at different time points: -6, which is 6 months before amyloidosis was diagnosed, -12, -24, and then our first period is -36 months. We use that period -36 to -24 months to determine the baseline prevalence of the red flag diagnosis. So we have considered that some patients could have high blood pressure, and that's why they develop chronic kidney disease. And so we don't want to misattribute some of these non-specific red flags to AL amyloidosis. And so that first period, 36 to 24 months prior to the diagnosis of AL amyloidosis, we are just looking at the baseline prevalence of these red flag diagnoses. But from -24 to 0, if a red flag starts appearing in the medical history, that is what is more interesting to us. And that is what we are considering as the incidence of a red flag diagnosis. And we use different statistical methods to calculate this time between the first instance of each diagnosis to time 0. We also looked at the pairwise co-occurrence between these red flag diagnoses using something called as the Coles coefficient, and we considered that if that Coles coefficient was more than 0.6, we would study it further in our next iteration of this study. So we identified a cohort of over 1,400 AL amyloidosis patients. The median age was 71 years, 54% were men, 63% were non-Hispanic white, 16% non-Hispanic black, and 5.6% were Hispanic. About 34% of the cohort also had diabetes, and about 77% had hypertension. The median length of EHR medical history that we had available was over 5.5 years, but ranged as high as little over 10 years. And on an average, there were 10 diagnostic occasions per year. So these are how these red flag diagnoses accumulate over time. So at the time of AL diagnosis, the median number of red flag symptoms were 5, with a median number of organ systems of 4. At 6 months prior to AL amyloidosis, there were 4 red flag symptoms and 3 different organ systems that we could identify within diagnostic codes. And if you look back to 24 months, there were 2 red flag symptoms with 2 organ systems. So these patients are identified with these red flag symptoms as diagnostic codes within the electronic health records. The most common red flag diagnoses at the time of AL amyloidosis diagnosis were dyspnea in over half of our patients, fatigue, 45%, neuropathy in 38%, altered bowels in 37%, edema in 37%, and heart failure in 36%. And the time from the earliest red flag symptom to AL amyloidosis diagnosis ranged from 3.2 months to as long as 21.4 months. So this figure shows for each of our red flags what is the timing and how does it accumulate, or what we call as the cumulative incidence. So I'll just give you an example of starting with maybe dyspnea because it was the most prevalent. So at 2 years before the diagnosis of AL amyloidosis, 22% of our cohort had a diagnosis of dyspnea, and that increased to 55% at time 0. But you can see the median time is a little more than 6 or 7 months before the diagnosis of AL amyloidosis. So when we studied the co-occurrence of these red flag diagnoses, the strongest co-occurrence and correlations that we saw were between dysphagia and macroglossia, between autonomic neuropathy and dyspnea, heart failure and cardiomyopathy, which intuitively makes sense because they're within the same organ system, and similarly renal disease and nephrotic syndrome. Some other interesting correlations were between purpura and neuropathy. These are completely unrelated, but they were more likely to co-occur, which makes us think that, yes, these were definitely related to undiagnosed amyloidosis, or fatigue and autonomic neuropathy, purpura and fatigue, syncope and autonomic neuropathy, and then finally altered bowels and autonomic neuropathy. So if you want to look at these in more detail, this figure shows them, and you have to identify the symptom on this x-axis and then match with a symptom on the y-axis. So for example, if you want to look at autonomic neuropathy and say abdominal pain, that would be this box over here, which matches abdominal pain here and autonomic neuropathy here. And this color represents the Coles coefficient, which is shown over here. So these types of studies always have limitations. And the first limitation is the limitation inherent to the use of EHR data in research. And we have to remember this when interpreting the results. There can be misdiagnosis, there can be coding errors, there can be variations in how symptoms are recorded, and different healthcare organizations may have variations in their EHR systems and their diagnostic coding practices. And so this is our first step, but we need to do a lot more work before saying that these are generalizable to all systems. Additionally, like I'd mentioned earlier, the early symptoms of AL amyloidosis, these red flags are often non-specific and can mimic other more common conditions. For example, if one has diabetes, you can develop neuropathy as a complication. You can have proteinuria, you can have cardiomyopathy. So it kind of mimics amyloidosis, but may have nothing to do with amyloidosis. And so because we lack the detailed clinical context, it is challenging to understand the severity and clinical significance of the red flag diagnosis. But on the other hand, because we have selected a cohort with at least 3 years of backward medical history, this allows us to assess a baseline prevalence period in that first year, and then just look at the incidence in the subsequent 2 years leading to the AL amyloidosis diagnosis. And this approach is very relevant because it is reflective of not just symptoms that patients are having, but it is reflective of that these are being clinically recognized by the healthcare provider and being put into the electronic health record. It means that this was recognized by the physician or provider as being of importance. And finally, I think the strength of the numbers and the diversity. This is a large cohort of patients. It represents a large number of centers they were seen at. And the demographics of the patients are very representative of the country. And so in conclusion, we show that our patients are being diagnosed within the healthcare system with multiple red flag diagnoses before AL amyloidosis is formally diagnosed. It is possible to catalog these diagnoses from EHR data, and this has the potential for earlier diagnosis of this complex disease. And we hope that we can use these data and these red flag diagnoses to develop clinical algorithms that can prompt systems to recognize AL amyloidosis early and do the right test to confirm the diagnosis in the right clinical setting. I want to end by thanking our funding source, which was the National Heart, Lung, and Blood Institute. If you're interested in looking at the paper, this is the link for it. It is open access, so anyone can download it and read it, along with the title of the publication. Thank you very much.